So my name is Andy Bamber. I'm a clinical psychologist. I'm a sort of a jobbing clinical psychologist. So I work clinically completely and don't have any time in my work plan for research. However, I'm going to present some research today that my colleagues and I did together. So I'm going to introduce my excellent colleagues, Lucy Gwilym, Senior Learning Disability Nurse, and Dr. James Bowler, Consultant Psychiatrist, who are part of this project as well. What I want to do today is, in a really short amount of time, briefly talk us through the multi-agency consultation meetings that we do in Bristol, where I work. I work for a learning disability CAMHS team in Bristol, as do Lucy and James. So the reason that we created MAC in the first place is because there are countless reports that all say the same thing, that early intervention is absolutely essential for working with our client group. We all know that it's hugely important, but what we also know, unfortunately, is that we are being in tier 3 CAMHS services. We have hugely high thresholds for young people coming into our services. Several years ago, Lucy came up with the excellent idea of creating what we've called multi-agency consultation meetings with the specialist schools in specialist schools in Bristol, in order to help merge the skills that they are working with on a daily basis in school and offering consultation to those teams. So I'll just very quickly kind of go through some of the statements from these papers about early intervention. So early intervention aims to prevent problems developing to more serious concerns later, and is continually stressed as crucial. That's from NICE, from the Challenge Behaviour Foundation, and from CSky. Children with learning disability are at increased risk of experiencing mental health problems. Agencies need to work together effectively to support young people and children with learning disability, particularly at high risk of being admitted to mental health hospitals unnecessarily. We all know this. This is a leaflet for the multi-agency consultation meeting. So I'm just going to kind of go through this to give everybody a sense of what they are. So the people who attend are learning disability nurse from our team, the school health nurse, the disability social worker from social care in Bristol, a clinical psychologist, that's me, the teacher from the school, and the school MAC lead. Now, often the MAC lead is a SENCO or one of the behaviour specialist leads at school. The referral process is that we get consent from the families, and often the families will join. We'll ask for the families to write a précis of the concerns that they're bringing, as well as the concerns that the school are bringing as well. What we really like to do is have a look at the positive behaviour support plans that the school are already running, as well as often the education healthcare plans that the school are wedded to as well. Okay, so the aim of the MAC is to provide a team formulation, as well as signposting and suggestions for behaviour strategies and community-based activities that may help the child and teacher to enact positive behaviour change and increased understanding. To develop, and then secondary to that is to develop professional working relationships and communication. And what I hope to show you over the course of this 20 minutes is that we've, in the MAC, have achieved both of those aims really well. What I also want to do, though, is asking the questions. We attempted to publish this work at the end of 2019, beginning of 2020, and it wasn't accepted, unfortunately. So if people in the questions are able to make comments that they think will be helpful for future versions of this paper, I'd be really grateful as well. Okay, so just to talk you through team formulation, when I was thinking about this lecture today, I was very aware that everybody coming to this PBS conference is coming from the whole point that we're here today is thinking specifically about PBS. What I wanted to do, though, is think slightly differently and think about what we in these multi-agency consultation meetings are offering, which comes under the PBS heading. We're offering a team formulation approach. So the school themselves are often bringing very in-depth, very well thought through, very well planned out behaviour support plans Now, what we try to offer on top of that is a consultation meeting where we are working with the school and working with the family, often to create a space where the school where the school teacher, for instance, is able to have 1 foot inside the system and then 1 foot outside the system in order to hold a space to think about alternative ways of conceptualizing the problems that people the young people are presenting in an early intervention manner. So formulation can be defined as the process of co-constructing a hypothesis or a best guess about the origins of a person's difficulty in the context of their relationships, social circumstances, life events, and the sense that they've made of them. It provides a structure for thinking together with a client or service, so the school in this case, about how to understand their experiences and move forward. Formulation draws equally on important sources of evidence. Clinician brings knowledge derived from theory, research, clinical experience, while the service user brings expertise of their own life and the meaning and impact of their relationships. In this way, formulation is used by clinicians to relate theory to practice. Okay. So in our service, we have, like I said, we have very high thresholds. Like most tier 3 CAMHS services across the country. The young person has to be under 18, they have to be registered with a GP in Bristol. They have to get consent, obviously. They need an IQ lower than 50, so it's a service for moderate to severe learning disabilities. The young person must present with challenging behaviour, emotional or mental health difficulties, sleep problems, severely restricted diets, toileting issues. They must have already accessed tier 1 or tier 2 universal or targeted services, and the referrer needs to specify the support. So in order to be referred into our service, all of these need to be ticked. What we hope to see during the early intervention process is those children who wouldn't necessarily meet the full criteria for being referred in. So we want to be seeing the children who are ticking these criteria, but not necessarily these in terms of making it an early intervention. So what I want to do is just kind of briefly work through a kind of a worked example, an anonymized worked example of the sort of conversation that we have. So in a 20-minute consultation, there isn't time, unfortunately, to go through to work on raw data, for instance, with the teachers. So what we often get is teachers who are doing a PBS plan that has come across a roadblock, and we really try to offer, with this team formulation approach, the space to be able to think creatively about that. So a young person, so this anonymized young person has a severe learning disability in autism. She's from an Indian community, from an inner city district. She seeks sensory input frequently or constantly. She's non-verbal and engages in making vocal sounds as well as what's called flapping and twiddling. She has very low muscle tone and struggles to sit in a chair for long periods of time, and has been seen by OT and physio for support with this. There's a very busy home life with several siblings and a new baby at home, and the two small living arrangements. So the reason for discussion is there are two main reasons for the referral. One was pushing the thumbs into her mouth and pushing the sides of her cheeks. This has the effect of breaking down the skin between her fingers and causing frequent skin infections. She's suffering from eczema on her forehead and leading to frequent scratching, leading to bleeding and scabbing over of scratches. Eczema is starting to spread over her face as well. And the concerns from school really that they were bringing to this multi-agency consultation meeting was they were really unsure about how to continue working with some of these concerns. And there were concerns from school also that the scratches may be caused by the siblings. What we have found there, just within that very brief discussion, I sort of get presented with a précis like that, and then by having multiple professionals around the table, it allows each of us to come at the conversation from our own points of interest. So, for instance, what we find is that when it comes to concerns around the school asking the question, around the concern that the scratches may be caused by the siblings. Having a social worker in the room was really helpful when it comes to having concerns around safeguarding at a point when the family aren't yet already referred to social care, because again their thresholds are very high. So it's so helpful to have a multi-agency consultation around these concerns in a early intervention setting. When I gave this, the last time I gave this lecture, we were in a room. I don't know if people remember that experience of being in a room with other people where you could actually shout out and form a conversation. So what we did was we spent a few minutes kind of brainstorming ideas and then précis them. But I'll just go through the précis of our the discussions that we had last time. So eczema could be impetigo, giving antihistamine to test this hypothesis. This may help to settle the swelling and the itching. On a very, very practical level, people hadn't discussed at that point, just sort of cutting the nails of the young person so as not to create more skin damage. Clearly, this is not a long-term plan for this person, but in terms of the immediate concerns around the safety of this young person, that was really helpful. People brought up the ideas around barrier cream and gloves, more physical exercise. There were from a health perspective, people were really bringing up the concerns around whether this young person had dental pain and toothache, and she was crying a lot when she was holding the side of her face and eating sweet things. Contact was made with the OTs around help with sensory workshops that they run, and social care got into contact with mum around helping to support her to visit the dentist. This family were not English speakers, so providing that extra social care support was really, really helpful. Okay. What we do every couple of years, Lucy has been doing an excellent job of doing thematic analyses on the feedback that we get from families, as well as from school, as well as crunching the numbers. So what I'm going to do in a minute is I'm going to present a few graphs about how the multi-agency consultation meetings have changed over time and the way that they've been better used by ourselves and by the schools that we work with. Okay, so the follow-ups from the teachers in SENCO is that to refer to specialist family dentists, so this was specifically the school's role, to refer to the Indian family support groups for support for mum and the children, to signpost to the GP re impetigo and antihistamines and pain management, and school to discuss with the senior management team if the dentist and GP are not actioned by the family with support, because that would then potentially lead to concerns around either safeguarding that it's or actually that more support needs to be offered. Teacher comments were lots of practical advice given and follow-up was offered to the families, so they were very thankful for the support offered for this particular young person, and the SENCO was very grateful. That's not a particularly helpful chart. This is a much more helpful chart. So I don't know if you guys can see, but we've got 2014, 2016, 2018, and then ideally we would have the 2020 data here. In blue is advice and signposting. In orange is referral to our service. In grey is multi-agency consultation discussion, and in yellow is complex needs. So in Bristol we have a complex needs meeting for young people for whom everything at a community level has been tried, and extra additional more costly support needs to go in. What we found in 2014 was that people in schools were using the multi-agency consultation meetings frequently as a way to try to get a referral into the service. So it was being used as almost a referral entry point. And then for a very small minority of the people, actually, their needs were so high that they needed to be referred straight to the complex needs group. By 2018, however, there were fewer. So a third of the people were referred in 2014, 40% in 2016, but by 2018, only a fifth of the people were being referred into the service, and 80% of the people were being used in a much more early interventive way, using advice and signposting. So this showed that over time, both ourselves as clinicians and the schools were able to use the multi-agency consultation in a much more early intervention way, which is exactly what we were hoping for.
We have 5 minutes left.
5 minutes. Jo, what do you want to do? Do we have enough questions, do you think, to take up for 5 minutes?
I haven't got any come in yet, so clearly you're
okay.
explaining everything really, really well.
Yeah, that could be it, couldn't it? Okay, so what this chart demonstrates is about the satisfaction of the schools for the multi-agency consultation meetings. So back in 2014, when we first crunched this data, the blue lines were a much greater spread of satisfaction. So there were some 10 out of 10, but then there were also some naught out of 10. Some people were just not happy with the offer that was being provided. Come 2016, and you can see that there's a shift in satisfaction ratings towards 10, and then by 2018, everything was 8. Obviously, the modal average here is 8 out of 10, and there's some 9s and some 10s out of 10 as well. So there's basically a big old shift, which effectively says the way that we're reading this data is people are more satisfied with the offer that that the MAC is creating, which is exactly what we want to be seeing. Okay, so the conclusions then. I'll just run through these conclusions and then we'll see what's coming up. Oh, there's some questions coming up. Cool. Jo, I can't read them at the same time as I'm reading this, so you can read them. Fab. Okay, so it encourages and facilitates early intervention through improving communication between our agencies. I have worked in different cities, different parts of the country. What I've massively appreciated about the relationships that we've developed through MAC is that I now have a very frequent consultation with the schools that I work with across the city. And it's hugely valuable that we have each other's phone numbers, we have each other's email addresses, and that communication is better because everything works on relationship. There's a huge amount of generalizing knowledge and strategies and resources that gets generated as a result of these sorts of meetings. MAC appears unique. Unique might be a strong word. We got pulled up by this, but it's certainly unusual that this service is being offered here in Bristol, and very positive for that. So it brings together the schools and multidisciplinary expertise. It's reduced the number of inappropriate referrals to LD CAMs, which is fantastic because it allows people to have those early conversations with us rather than making a referral which ends up getting bounced back, which doesn't suit anybody. And it acts as a tool for giving agency a sense of hope and understanding for the people who are involved in the MAC meetings. Okay, fab. So that's me. Whistle stop.
Okay, brilliant. Well, thank you. So we have a couple of questions.
Great.
So the first one is, how many schools are you supporting, and how many pupils per school tend to use the MAC model?
So there are 3 schools in Bristol that we serve. They all range in their expertise from severe learning disability to sort of mild to moderate learning disability. We have 1 meeting per half term, so that's 6 meetings per school per year, so 18 meetings per school year, and we tend to split things up in our team. That I think I do 2 of the 3 schools, and the nurses split it up as well. So I do probably about 12 a year of the 18.
Brilliant. So 1 minute. So very quick question is, what are your thoughts on EHCPs, and have you found them useful or a barrier?
That's fascinating. And in order to understand that question, it would be really helpful to know where the person is coming from, whether the person asking that question is a parent, for instance, whether they are working in a school, whether they're working clinically. My experience from a personal perspective, working clinically, is that my only relationship with them ever really is as a tool for helping that young person get from an inappropriate school setting into a more appropriate school setting. So that's really the only relationship I have with them. I attend EHCP review meetings, and I'll offer reports to them, but more usually the relationship that I have with the young person comes via our own sort of specific behaviour support plan, and the clinical work that we do, as opposed to the sort of the bigger, if you like, more generic EHCP document.